Hey guys, it's me, Jim. You're probably thinking to yourself, what in the world am I going to snack on? Well, I'll tell you what. Go to our website at brainwaves.me and check out some of the links to NatureBox. Whether you're into dried pineapple rings or white cheddar caramel popcorn, you're bound to find something tasty, healthy, and affordable. Your first 3 snacks are free if you use the links from our blog. NatureBox. Eat well, live better. Jim Siegler here for the Brainwaves podcast. It's the end of May, and the summer is fast approaching. For some of you, this marks the end of another year in medical school, residency, or fellowship, and for others of you, maybe you're recertifying your boards this fall and you're looking for some study materials. Hopefully, this week's program will be insightful to each of you as we review some of the major drug-drug interactions among anti-epileptic medications. There aren't all that many you should be aware of as a neurologist in your day-to-day practice, so today's program will be pretty short. In full disclosure, today's show is a rerun from 2016, with some minor tweaking of the sound quality and some major deleting of the weirder things that I said 2 years ago. But all the important content was preserved. Anyway, here you go. In general, AED interactions with other pharmacologic agents are modest at worst. No drug ever really renders another drug useless, nor should one drug instantly make the other toxic. But you really should be aware of them, especially in patients with difficult-to-control epilepsy, or if you plan to pass your board exams. As a med student, you're told that if you can distinguish the hepatic enzyme inducers from the inhibitors, you'll be alright. But like all things neurology, the answer is not so simple. When thinking of inducers and inhibitors, you'll recall we're talking about the drugs that target the cytochrome P450 hepatic enzymes. But these drugs also target other hepatic enzymes like glucuronidase transferases, which inactivate drugs like Lamotrigine, valproic acid, and oxcarbazepine, and epoxide hydrolase, which breaks down drugs like carbamazepine. Let's take a minute to review the inducers and the inhibitors. As you know, the most important and really only inhibitor of the cytochrome P450 system is valproic acid. I remember it as a major inhibitor of the hepatic enzyme function because one of its major adverse effects is hepatic toxicity and hyperammonemia. So think of it that way: valproic acid, liver inhibitor, liver toxicity. In contrast, the major inducers include the P drugs, P for promoter of liver function, phenytoin, primidone, and primidone's active metabolite phenobarbital, and also carbamazepine. I really can't help you there, you'll just have to remember that carbamazepine is an enzyme inducer on your own. And while I said that the impact of enzyme activation or inhibition is modest with these therapies, some drug levels can be enormously affected. For instance, patients on valproic acid, remember the inhibitor, patients who are co-medicated with an inducer may have a 50 to 75% reduction in the serum valproate levels. Lamotrigine levels may also drop by 50% or more in the presence of an inducer. On the other hand, patients on lamotrigine or phenobarbital who are co-medicated with valproic acid may have a 2-fold greater serum levels of lamotrigine or phenobarbital. Therefore, if you've got a patient on VPA and want to start lamotrigine, you must start the lamotrigine titration at a lower initial dose and increase more slowly than usual. Or if you've got a patient on valproic acid and you want to start phenobarbital, which has an astounding half-life of 80 hours in adults, serum phenobarbital levels may become toxic after several days or weeks at doses that you may think to be minuscule. That being said, thinking of these drugs as either inducers or inhibitors really limits your understanding of their pharmacologic complexity. Distinguishing the inducers from the inhibitors will barely help you pass the med student's clerkship exam. You've got to take it to the next step. Primidone, as I've just mentioned, is metabolized by the P450 system into its active anticonvulsant metabolite phenobarbital. So, as an inducer of its own metabolism, increasingly greater doses of primidone may more rapidly escalate the serum levels of its active metabolite. The converse is true of carbamazepine, which induces its own metabolism, thereby inactivating it. So you've got to be careful with dose adjustments for each of these meds. There's also evidence that the quote-unquote inducers and inhibitors also act via various mechanisms at the level of the GI and renal systems, where they modulate expression of drug transporters, facilitating or inhibiting absorption or excretion. Next, I'd like to talk about some of the particular interactions that are most relevant to women. Of the more clinically relevant AED interactions, OCPs are something you have to know backward and forward. Lamotrigine is the main drug whose therapeutic and toxic levels are affected by OCP use. Lamotrigine, which is the broad-spectrum AED of choice for women of childbearing age and pregnancy, is more rapidly metabolized in OCP users. Serum levels of lamotrigine drop by about 50% in young women taking OCPs, or they may acutely rise by 200% during the quote pill-free week. So monitoring of drug levels is necessary in patients thinking about starting, stopping, or changing their contraceptive regimen. Conversely, some AEDs reduce the efficacy of OCPs, and these are the enzyme inducers, remember the P drugs and carbamazepine, as well as lamotrigine, topiramate, felbamate, and oxcarbazepine. A lot of these interactions are dose and drug dependent, and we're not going to get into the details, but as an example, think of carbamazepine, which is a particularly potent inducer of OCPs, and can reduce serum levels by 50% at normal carbamazepine doses. In contrast, topiramate and lamotrigine produce only a modest reduction in the effect of OCPs, on the order of 20% or less. But topiramate is not a very significant inducer of OCPs until you get up to doses of 200 milligrams daily. Newer drugs like Aptium and Fycompa may also affect OCP levels in women. Moving on to pregnancy next, medication levels can certainly be influenced by normal physiologic changes of gestation. Classically, as you know, lamotrigine levels are dramatically affected, especially during the second and third trimesters. In fact, pregnancy increases lamotrigine clearance by over 300%. But does this have any clinical consequences? The answer is yes. Absolutely half of patients will have a worsening in seizure frequency because of this. And after delivery, almost instantly, you should have a plan for your patient to dose reduce their lamotrigine in order to prevent acute toxicity. Some investigators have recommended a 10-day taper back to preconception dosing levels, plus or minus an extra 50 milligrams to counteract the effects of sleep deprivation from having the child. You know you're not getting any sleep. Or you could alternatively cut the dose in half on postpartum day 1 and check a level after 1 week. Obviously, I'm not making any generalizable recommendation here. Each situation is unique and the schedule should be adjusted according to the patient and their individual pharmacokinetic profile. The best way to prevent sub-therapeutic levels during pregnancy and supra-therapeutic levels postpartum is probably to check lamotrigine levels in the serum on a monthly basis during gestation, and then in the week postpartum, and adjust the dosing when necessary.
Oh my stars, have you read the news? It makes me blue, unlike everything in my electric dream. Yeah, you see I'm going away.
Okay, that was a lot, and we didn't even get into the interactions with non-anti-epileptic drugs. While I'd love nothing more than to regurgitate a chart of interactions to you, I'm trying to keep these episodes short and sweet. So the bottom line is, if you're looking for a low-profile AED, I usually go with levetiracetam, gabapentin, and pregabalin. The latter two almost never being first line for anything epileptic. That wraps it up for our program this week. Like I said earlier, a really quick show. I hope you found it useful. Since the show originally aired in early 2016, at least one new AED has been approved by the FDA, brivaracetam. It's a pyrrolidine that's structurally analogous to levetiracetam, but with 20 times greater affinity for the same protein target. Brivaracetam is used in the treatment of simple and complex partial seizures, and its major interactions include that it can raise levels of carbamazepine or phenytoin by reducing their metabolism. For more information on AED drug-drug interactions, and for some related content, check out our blog this week at brainwaves.me. You'll even find a few links to other shows that walk you through the thought process of selecting an AED in a patient who presents with epilepsy. As always, thanks for tuning into our program. If you like what you heard, or if you have some feedback for us, shoot us a message on Twitter at Brainwaves Audio, find us on Facebook or Instagram, or just leave us a few stars on iTunes or wherever you get your podcasts. The Brainwaves podcast is produced out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. This week's music was courtesy of Justin Warren, whose first feature film was just released, I might add. Then There Was Joe, starring Ray Grady and Justin Warren. For more information, check it out at thenThereWasJoe.com. I'm Jim Siegler, and I'll talk to you again soon.